Thanks for coming, everybody. My name's Eric Bernstein. I'm a medical oncologist here in town. Brendan Curti is a former partner of mine when I worked in Oregon. He's a fantastic clinician and an extraordinarily accomplished researcher. He actually has, I think, as many pages or more pages in his CV than I have publications in mine. So he's really a national leader in immunotherapy, in the treatment of melanoma and renal cell cancer. Dr. Curti had previously, he was originally from the East Coast. He'd worked at the NIH before establishing a clinic in Portland that is really doing world-class, cutting-edge immunotherapy research. They have developed drugs there that have gone from thinking about putting them into a mouse to now clinical trials, all under one roof. So it's a really exciting place to work, and he's a fantastic researcher, and he's actually pretty funny. So I'm very much looking forward to hearing his talk, and I really appreciate him coming out. He flew out today and is going back tomorrow, so he's making a quick trip just to give this talk. So thanks for coming, Dr. Curti.
Thank you. Again, thank you for that very kind introduction, and thank you all for coming this evening. Can everyone hear me okay? Or okay. I'm not sure who's controlling the volume, but I'll do my best to speak up. So I'm going to discuss new targets and new treatments in melanoma. I've been doing melanoma research for over 25 years, and frankly, there wasn't much to talk about until the last 3 or 4 years, and so I'm happy to share some of that with you. Let's proceed to the next slide. So it's become, I'll say, customary to provide disclosures at all talks, and I'll say, not shockingly, our cancer center receives research money from pharmaceutical companies, from the federal government, from a variety of different foundations that support cancer research. And so I'll just say, in the old days, 10 or so years ago, most cancer center funding would come from the National Cancer Institute or the NIH. Nowadays, most places that do cancer research understandably have to diversify, and we really couldn't do the work that I'm going to talk about without this sort of partnership. We'll move on to the next slide. This is the most important disclaimer, and as you'll see as we talk tonight, I believe in immunotherapy as a way to treat cancer. This has become, I'll say, a fairly accepted notion, but it was really quite sketchy up until a few years ago, and perhaps some of the reasons for that will also become apparent as we talk here this evening. So you'll hear about immunotherapy, but you'll also hear about other ways to treat cancer, and again with a focus on melanoma. Move on to the next slide. So these are just some factoids about melanoma. There are about 80,000 people in the United States who will be diagnosed with this in the coming year. Melanoma is, I'll say, a distant third compared to other skin cancers, basal cell skin cancer, of which there are roughly 1 million new diagnoses a year. Squamous cell cancer is roughly 250,000 squamous cell skin cancers. But there are some great differences in the clinical behavior of melanoma, which we'll get to in the upcoming slides. Actually, we'll go back to the prior slide. About 9,000 individuals a year die from melanoma, and again, that makes it very different from other skin cancers. The incidence of melanoma has been increasing, and although the rate of rise is perhaps not as great as it was in the 70s, it is one of the cancers in which there are more and more cases per year in the U.S. No one would say that Portland, Oregon is in the Sun Belt, but yet it is part of the country where the incidence of melanoma is actually about double what it is here in New Mexico. We don't understand all of the reasons for that. Some of it is migration. People from sunnier parts of the world have moved to the Pacific Northwest for whatever reason. Some of it is the gene pool. A lot of people of Northern European descent happen to live in the Northwest who are generally fair-haired, fair-skinned, and those are other associations with skin cancer, including melanoma. Men are more likely to get melanoma than women. And although the incidence is greater in older people, it can be a diagnosis in young individuals, even children, 10 or 15-year-olds, can get melanoma. That is thankfully rare, but it is by no means rare in 20 or 30-year-olds. I'll go to the next slide. This depicts, again, some factoids about this disease. And like most cancers, with early stage 1 means a small melanoma, basically a mole or freckle that is removed in the dermatologist's office. Stage 2 is, I'll say, a little deeper, a bigger mole or freckle. Stage 3 means regional lymph nodes are involved. Stage 4 means more distant disease. One of the things about melanoma, and I'll illustrate this in another slide as well, but if you look at the stage 1 patients in the table on the upper right, that even patients with very early stage melanoma can die as a consequence of this cancer. And again, that's very different from other skin cancers and also most other tumor types. The pie chart also illustrates true enough that most patients are diagnosed with localized disease, and that's good, but even patients with localized disease, 40 or 45% of them will develop a recurrence of their melanoma later in their lifetime. And so in our society, in our culture, 5 years cancer-free, most people think, well, of course that's good, and not to worry after that. But in the case of melanoma, it's a diagnosis that can return not just 5 years, but 10 or 20 or 30 years after the initial diagnosis. Proceed to the next slide. This is just yet another way of illustrating the increase in incidence, and it's projected by 2015 that about 1 in 50 will develop melanoma during their lifetime. So the main risk factor for skin cancers, and specifically for melanoma, is ultraviolet radiation, most of which, of course, we get from the sun, but some of which comes from tanning bed facilities. And so this is, I'll say, the public health slide that I have in my presentation here this evening. Tanning salons and the use of tanning beds increase the incidence of skin cancer. And even states that have some restriction in terms of getting parental permission and such, that doesn't necessarily lower the use. Tanning is addictive, and there's some interesting biology behind why that is. The way that the body synthesizes melanin, the pigment in the skin, which of course is where the name melanoma comes from. That synthetic machinery also overlaps with the production of the body's own opioids, morphine-like substances in the body. And so there's some interesting biology that, thank you. There's some interesting biology that tanning truly is addictive because it triggers these opioid pathways, at least in certain patients. There have been a handful of states that have banned tanning bed use, at least for teenagers. California was the first one. The state of Washington just recently passed a similar law, and actually it was at through the efforts of the family of a patient that I took care of. Her name is Ashley Trenner. She unfortunately died of her melanoma, but if you want to see a very compelling YouTube video about the dangers of tanning and what happens, she offers a very heartfelt and compelling story. And again, her family organized an effort in the state of Washington to ban tanning bed use for teenagers. And again, this law was passed just about 2 weeks ago. So these graphs illustrate how patients do over time. And so I realize it's kind of a gloomy way to view the world, but oncologists think of how long our patients survive or when their cancer comes back after the initial diagnosis. And so I realize these line graphs are difficult to see, but basically the upper lines relate to early stage melanoma, the lower lines relate to more advanced disease, And all the lines start out at 1, meaning 100% of people are alive, and over time, the curves trend downward. Not surprisingly, the lower curves, people who present with advanced stage disease, can die within a very few years of the initial diagnosis. But if you look at the upper curves, the early stage patients, they have a negative slope. And again, this is just to illustrate another way that early stage melanoma can get you. And again, we need to help these patients. As I'll be saying, there's some new technologies, some new ideas that we may be able to offer improvements for them. Okay, so, okay. Okay, so, right you are, thank you. So the next slide. And so it gives me no pride to emphasize this, but the results of our clinical trials in melanoma are not just bad, but consistently bad. And so each of these lines, again, I know they don't project, but they illustrate the survival of melanoma patients who participated in clinical trials in the 1980s, the 1990s, and in the early part of this century. And so there is no difference between those three lines, but hopefully that will be changing. We'll go to the next slide. So some have referred to this as the long dark tunnel. And so no survival benefit in melanoma treatments over the last 30 years, although that is changing. It took melanoma researchers the better part of 20 years to come up with a new and better idea. So between 1992 and 2011, there were no FDA-approved new medicines for melanoma, but since 2011, there have actually been 4 medicines and soon to be a 5th approved for the treatment of advanced melanoma. Until 2011, first-line therapy was certainly of questionable value and really no established second-line therapy for these patients. And there's one more line to appear on the slide. The treatment of choice is a clinical trial. And so I'll be talking in the upcoming slides about several clinical trials that have been done recently. I state the obvious, but it's the only way in which new treatments can be found for our patients with cancer. Clinical trials are not for everyone, and certainly it's very important to understand, for patients to understand what they're getting into. But again, it's the only way that we can raise the bar with our new treatments. So what I'm going to talk about next, I'm going to make a little bit of a detour and describe a little bit about how the different components of our immune system work. And so this cartoon depicts an exchange or interplay between antigen-presenting cells and T cells. So what do antigen-presenting cells do? Well, an antigen is something that the body can recognize potentially as foreign. But there are many steps in processing the proteins that become these antigens, and then they have to be, again, shown to or presented through a protein receptor to a cell that can do something about what is foreign in the body. And I'm going to focus on T cells, which do have the ability to attack tumors, at least under the right circumstance. So the way these cells work, there are a number of different signals that can slow them down. PD-1 and CTLA-4 are 2 examples, and I'll be talking more at length about those. I won't be talking much about OX40 and 4-1BB, but these are other signals that are very important to the life of these immune cells and regulate how they behave. We can go to the next slide. So that little cartoon was just a focus on the main signals that these immune cells are looking at. But there's actually quite a few more, and this cartoon is, again, a simplification. There are at least 70 different signaling pathways that manifest on the surface of T cells. And if we go one slide more, it's not just what's happening at that cell. All of these different immune cells are communicating with each other, interacting with each other, regulating each other. And so we mentioned briefly about antigen-presenting cells and T cells, but there's many different flavors of these immune cells. With a device called a flow cytometer, it's my understanding from the history of it, some of the technology for that was actually developed at Los Alamos, but it's a way of staining cells, looking at different proteins on their surface and quantifying what proteins are there. And now we can look at between 10 and 15 different of these proteins on the surface of T cells. And based on the distribution of all of those different cells, some have proposed that there are on the order of 250,000 different T cell subsets. And so, although immunotherapy is great and we understand some of the mechanical parts of it, it's very complicated, and honestly, there's a whole lot more for us to understand. Go to the next slide. So this is maybe a little simpler depiction of how these cells work, and so I'll use an automotive technology, or an automotive analogy, I should say. And so CTLA-4 is one of these pathways, and it's been described as a brake on T cell activation. It slows down the activity of these cells. The reason why it's there biologically is that you don't want a revved up immune cell attacking your lung or kidney or some other normal part. So the body has its way of keeping these cells in check. This just illustrates other parts of the immune response. And so putting the key in the ignition is akin to the T cell receptor encountering one of these antigenic, one of these foreign proteins. There's hope that if we had a good vaccine, we could steer the immune response. And there's also stuff that revs the immune system up. There's a subliminal message there for interleukin-2, which I'll mention briefly as another immune stimulator. And again, the normal function of CTLA-4 is to put the brakes on T cells. So with that as a background, I'm going to talk about a clinical trial which led to the approval of an antibody-based therapy in 2011. And so part of my illustration here is not just to talk about the results of it, but also to talk a little bit about how clinical trials are constructed and how cancer researchers think about their problems and try to solve them. I know that I'll say all different scientific disciplines or endeavors, they have different perspectives, but this is how cancer researchers go about it. So we'll go to the next slide. So with this trial, it was a test of a monoclonal antibody, so anything that ends in mAb is a monoclonal antibody. And in this case, the monoclonal was referred to as ipilimumab. And it was given in conjunction with a vaccine, something called GP100. GP100 is a protein that is present on some melanoma cells, and specifically this is a small fraction of that protein. So, and so the way this study was constructed was to look at the IPI plus this vaccine, the IPI plus a placebo, and the vaccine plus a placebo. So why would we design a trial this way? Well, thinking back to when this study was proposed, and so the history of this goes back to about 2004, 2005. As I mentioned before, there was no second-line treatment for patients with melanoma that was recognized as conferring any real benefit. So you notice the patients who participated in this study all had previous treatment for their widespread melanoma. And so the FDA said, well, really you should have a placebo, but nobody was really comfortable with, I'll say, a true placebo for these patients. So there was a vaccine, again, this GP100 stuff, which had been worked with at the National Cancer Institute and has about a 3% response rate. And so you could say that's gloomy and depressing, and I won't disagree with that, but that was the state of the art in 2004 or so when this study was configured. And so we can go to the next slide. These curves depict how these patients did. And so the upper two curves are the patients who got the IPI or ipilimumab, and the bottom curve is the patients who got the GP100 vaccine. And so these individuals, and of course, all of these curves start out at 1 or 100% of patients are alive. And in time, unfortunately, patients are still dying or succumbing to their melanoma, but this group of curves is above that baseline curve. And so certainly we would like everything to stay at 1 and go across like that, but we have not yet found that technology in melanoma or virtually any other cancer. But again, this was considered an advance. We treated at our cancer center some of these individuals, some of whom have been followed out to about 7 years. And so I'm happy to say I know some of the circles on this upper curve, and Eric may as well from his time in Portland. So one of the remarkable things about immunotherapy when it works is that, well, when it works, it really does work. There can be these durable responses in at least some of our patients. This is just a table depicting response rates, and I won't belabor this other than to say that the response, and the way oncologists define that, is the percent of patients basically whose scans show improvement was around 11%. Again, nothing to be boastful about, but yet the patients lived longer, which was really the point of this study. So we'll go to the next slide. So I'm going just to describe a few of the side effects of this because it's so very different from chemotherapy and how chemotherapy works. And so when we started working with this antibody, it became apparent that some, I'll say, kind of funny things happened. Patients developed sort of an unusual rash. Some people got diarrhea, sometimes quite bad, and some changes in the endocrine glands of the body. These side effects are reversible, they're manageable, but again, very different from chemotherapy. You can go to the next slide. So this is an example of the rash, and this is perhaps hard to see, but you can see some parts of the skin are sort of darker than others. And so in this patient, their immune cells are attacking any cell in the body that's making pigment. That includes the melanoma, but it also includes some of the normal pigment-making cells in the skin. This is an example of iritis or eye irritation. You'll have to take my word for it, but that's an angry colon, and at any rate, there's an infiltration of immune cells in the colon, which gives rise to the diarrhea. We'll go to the next slide. This is a rather unusual condition that was hardly ever described in the medical literature, but people got swelling of their pituitary glands after this treatment. And so it's believed to be a consequence of immune cells infiltrating this pituitary gland, but this is not a part of the body where one can biopsy. As you can see, this is an MRI of the brain, and we don't want to go mucking about with that too much. So this is basically a scan finding. So with ipilimumab, it was really a trailblazing immune therapy. And again, it was based on an understanding of how our body's T cells work and the mechanics that can turn them on or off. There's still lots of work with ipilimumab. I'm going to show an illustration in some of the upcoming slides. It was approved by the FDA in 2011, and 4 doses go for the budget price of $120,000. And so I'll just make an editorial comment and say I understand why this antibody should be much more expensive than, say, a bottle of aspirin or similar, but cancer treatments are expensive. So what's next? And so I'm going to talk about another one of these T-cell pathways known as PD-1, and specifically an antibody that has been engineered against that pathway. We can go to the next slide. And so, again, this is another automotive analogy here, but the use of PD-1 is another one of these braking signals, another one of these inhibitory signals in our body's immune system. And so if you provide an inhibitor to a negative signal, two minuses make a plus in immunology as well as arithmetic. And so the idea behind this was that, again, removing or diminishing this inhibitory signal would do something good to our body's immune cells. This is, again, another cartoon about the forest of proteins that exist on our immune cells. And so this just calls out the PD-1 pathway, which, again, has several different moving parts. There are different antibodies that are being constructed against different parts of this pathway. So there's more than one target within it, which may have some medical benefit, not just in melanoma, but also in a variety of other cancers, including lung cancer, kidney cancer, perhaps ovarian cancer as well. So the next clinical trial I'm going to talk about is something that combines nivolumab, another hard to pronounce name for a monoclonal antibody, again, this time directed against PD-1, and its use in combination with ipilimumab, the first antibody that we talked about. And so we can go to the next slide. The basis for this study was in part from a mouse model of melanoma. Now, obviously, mice with melanoma are different than humans with melanoma, and that's ultimately a good thing. But this is more an illustration of how we take some preclinical or laboratory science and try to build it into a treatment for our patients. And so these mice got a control antibody, an antibody that was neutral, didn't have any effect on the melanoma itself. And each one of these lines represents a tumor growing in an individual mouse. If you give a PD-1 antibody, all the tumors still grow, but maybe you could say it took a little longer, but that's not much to write home about. Similarly with anti-CTLA-4 or an ipilimumab-like antibody. But when you put the two together, a few tumors grow, but most of them do not. And so these are similar survival curves with the mice as I depicted in the clinical trial. And so this was felt to be a very strong rationale for combining these two agents. Now, I'll say curing a mouse of melanoma is, I'll say, fairly straightforward. Even I can routinely cure mice of melanoma in the lab. 97% of the time, experiments that look like this preclinically do not show clinical results in humans of the same magnitude. And so we need better models, but I'll say it's the best class of models that we currently have to work with. So when the combination of these two antibodies, the anti-PD-1 and the CTLA-4, were given to humans, something surprising and good happened. And so this is another depiction of how cancer doctors look at data. And so this is known as a waterfall plot. And so the zero line means basically the patient's baseline tumor. And so how do you determine a baseline? Well, a scan is done, and there are a set of rules for measuring the tumor deposits in the patient and basically tallying up the total. If over time the tumor shrinks to, say, 50%, well, you would have a bar that goes down by 50%. If your tumor grows, it's all above the zero line. So certainly you want to be one of these bars down here and not one of those up there. So we'll go to the next slide. So this depicts some of the rather dramatic responses of this combination. And so these are CT scan images, and this is through the mid-portion of this patient's chest, and you can see these various large bumps, if you will, which are all melanoma deposits. And a few weeks later, these are all virtually gone from the patient. This is yet another depiction of cancer patient data. This is called a spider plot. So each of these lines represents the tumor response of an individual patient, kind of sort of like the mouse data. And so in the world of immunotherapy, a melanoma disappearing in 10 to 15 weeks, that's actually a very remarkable finding. And before work like this, we hardly ever saw that in our patients. And so, again, there's some traction, and certainly this idea is being pursued in other studies, and I'll mention a little bit of that later. This is admittedly a small study, and 53 individuals in this survival plot. And again, this only goes out to about 3 years. But as I mentioned before, the tail on the curve before was right about at the 0 line or a few percentage points above it. There's a tail on the curve, maybe in the 15 to 20% range, and maybe by combining some of these immune-regulating antibodies, we can push that tail on the curve much, much higher. There's a lot more work to be done, though, to verify that this is, I'll say, an applicable or sound technology. So these conclusions were actually from a international meeting on cancer research, and this was one of the highlighted presentations. But again, the combination of these antibodies caused, I'll say, a lot more responses, or a much higher proportion of responses, and much faster than we had seen before. There were side effects, but they were manageable, and again, nothing like traditional chemotherapy side effects. And based on this early work, there's a large trial that started in early 2013 and actually finished enrolling patients about a month ago. And so that is the study that will hopefully allow us to determine just how good a result, or just how good the result will be from combining these two antibodies. You can go to the next slide. So I have this as just a depiction for historical reasons. And so I've been talking about more modern immunotherapy, but there's been an immunotherapy that's been around for a number of decades, namely interleukin-2. And that was something I fit in on one of the automotive slides before as being the equivalent of stepping on the gas. Interleukin-2 is an immune protein that is present in our bodies, and it basically provides fuel for the immune cells, specifically these T cells. So when IL-2 is around, these T cells will proliferate, make more copies of themselves. They will also rev up. They're much more effective at killing their tumor targets. And so interleukin-2 was first given to a human in 1983 at the National Cancer Institute. It was approved by the FDA in 1992. And one of the remarkable things from those very early studies was that there was a tail on the curve. Now, the way this graph is, it parses people who had a complete response. Seemingly the scans got all the way better after the treatment versus those who had a partial response or any response. And these patients have actually been followed for 15 years or more. And so back when I was as young or younger as Dr. Bernstein, I took care of some of the ticks on this curve, and so I still get Christmas cards and emails from some of these individuals, so I know that they're still out there. And so, again, durable responses with immunotherapy are possible. You can show the next one. And so this is actually from our own IL-2 program, and so we're actually, oddly enough, in Portland, Oregon, one of the busier IL-2 centers in the country, and so we have over 15 years of data and currently over 400 melanoma patients. And so similarly, a tail on the curve of our complete responders. And if we can go to the next slide. And this is, I'll say, perhaps deliberately gaming our own data, but I will confess it fully that with many cancer therapies, but especially immunotherapy, some patients, their scan gets all the way better, but a lot of times the scan is maybe partway better. And so what does that mean? Is that a bad thing? And so what I'm trying to illustrate is that's not necessarily a bad thing, because some of those individuals, some of these tick marks, and within our own melanoma program, there are 53, as I recall, of these individuals who their scans didn't get all the way better, but yet over a long period of time, their melanoma did not regrow. And so that may just be good fortune, or it could be that the interleukin-2 and the immune cells that were spurred on by it have fought the melanoma to a standstill, or it could be that what we're looking at on the scan is some sort of a scar or the like. But even without scans that are 100%, some of these patients will do quite well over time. So I'm going to shift gears and talk about a different technology platform, if you will, for attacking melanoma. And again, this is work that has only come about within the last 3 or 4 years or so. And so we'll go to the next slide. And so, again, this just depicts one of the many different growth pathways that are near and dear to melanomas. And so sometimes this is referred to as the RAS, RAF, MEK, ERK pathway. One of my comments that I make to some of the oncology fellows who rotate through the lab is that in the English language, there are something like 17,530 odd 3-letter combinations you can make in a 26-letter alphabet. So there's still plenty of these proteins that oncology fellows can discover and work on. Some have estimated that there are, I'm just showing you one main pathway, which certainly is important to the growth of melanoma, but some have calculated that there may be as many as 20,000 ways for a melanoma cell to circumvent these main growth pathways. And so I'll say that's more than mere oncologists can understand, but it does illustrate how resilient melanoma is. Having said that, knowing that these pathways are important has enabled us to develop some medicines that can block these pathways. And so beyond that, and so this illustration is just trying to show that among these growth pathways, there are mutations, alterations of those pathways. And so the distribution of them, though, depends on what part of the body. And we'll go to the next slide. And I know these are, I'll say, some ooky pictures, but they illustrate some different presentations of melanoma. So this is a skin melanoma that did not occur in a sun-damaged area. About half of those patients have a mutation in this BRAF pathway, about 20% in another pathway. In sun-damaged skin, the mutations are different. In melanomas that arise on mucosal surfaces, different yet. Melanomas, this is the bottom of someone's foot. Again, the distribution is different yet again. And melanomas that occur on the retina, the back of the eye, have a completely different set of mutations. We didn't really have this knowledge, again, 3 or 4 years ago, but identifying these targets has led to some new treatments, and I think many more in the years to come. So this is an illustration of targeted therapy, and again, another clinical trial about how this laboratory science was translated into treatments for patients. And so this involved a new medicine called vemurafenib in patients who have this particular mutation for their melanoma. You can go to the next slide. So these are some, I'll say, different imaging technology known as a PET scan. And so PET imaging involves the injection of a radioisotope, fluorodeoxyglucose, and in a way it's depiction of energy usage in the body. The brain uses a lot of energy, that's good. The heart uses energy, that's good. But melanoma also uses a lot of extra energy, and so you can see these multiple black dots on the scan. This patient received this vemurafenib, and as you can see, all of these abnormal areas have essentially disappeared after this medicine. And these are some other depictions on the scans. And this up here are microscope slides of changes in some of these regulatory proteins. And so it's basically verifying that the laboratory science actually occurs in humans. And so, again, this is another waterfall plot with many of these bars going below the 0 line, meaning that the patient's melanoma is shrinking. One of the challenges of this type of therapy, though, is that it doesn't last forever. And so these bars, you'll notice some of them have a red dot at the end. And so in these individuals, the melanoma responded for a time, but then started to grow. And so that's one of the challenges of this technology, and something that we have to learn much better to adapt to and to thwart the melanoma and its ability to overcome these inhibitors. Again, a plot of how these patients do compared to a chemotherapy medicine that's used in melanoma, and the patients with targeted therapy do better. But unfortunately, this curve is trending down, and in curves that have gone out beyond a year, the trend continues. And so we'll just keep forwarding for this slide. And so, again, this mutation known as BRAF is present in about half of melanomas. They can be blocked with vemurafenib. The medicine, I didn't talk about the side effects, but it's pretty well tolerated as cancer medicines go. A very high percentage of patients will have shrinkage of their melanoma, at least half, maybe 60 or 70%, but the median duration of response is about 7 months, and so the remissions are not durable. It goes for the bargain basement price of $9,800 a month, or roughly 117 grand a year. The FDA has recently approved 2 new targeted medicines, the names of which are dabrafenib and trametinib. The 2 of those together cost $17,000 a month. And so I'm not trying to scare you away from seeing your doctor because of the cost of medication, but it's just an illustration that these technologies, they're great. It's always nice to have something new and something, of course, that helps patients, but there are real, I'll say, medical economic implications of some of these new therapies. And so, what does the future hold? Well, I'll quote Yogi Berra, who supposedly said that it's especially hard, it's hard to make predictions, especially about the future. And so none of us, of course, really know what's going to happen. But those of us who are biased to believe that immunotherapy is good will say that it'll remain a first-line treatment in melanoma and likely many other tumors as we understand more about the immune system and how it behaves and how it can be induced to attack the tumor and how we can sustain immune responses. There's a great deal of work looking at trials with PD-1, with IPI. There's another T-cell directed antibody known as OX40, another one called 41BB. There's another one called KIR. And so there's a long list of these things. And again, the hope is that as we learn more about these pathways, we will have much better treatments. It would be nice to know beforehand, though, which patients would respond and which or who would perhaps not respond to a treatment. And so there's a great deal of work in biomarkers, again, identifying patients who are likely to benefit from these therapies. There is an idea that you can come out with an immunoscore, and so This is an examination of the immune cells that are in and around a tumor site to determine how many and what the balance is of these immune cells, and use that as a way not just to estimate prognosis, but also potentially response to therapy. And I'll say, again, especially with the expense of these treatments, focusing on a treatment that works as a first line would be better than taking a guess and doing it less efficiently. This has been true in virtually all of cancer medicine, but there's hardly any cancer that responds to just one medicine. Things are used in combinations. And so, again, as the future unfolds for melanoma, I think that we'll be understanding these combinations and applying them in many more effective ways. And the work that we're doing now in patients with more advanced melanoma hopefully will translate into better treatments for earlier stage disease. As I mentioned early on in the talk, even patients with stage 1 or stage 2 melanoma can get into real trouble during their lifetimes. And so, of course, we want to be able to help those patients before they have widespread melanoma. And so a lot of work to be done in the present, but in the next 20 or more years to come. So I thank everyone for their attention. I'd be happy to answer questions that people have.
And alternatively, if you'd prefer, you can write your questions down on the cards. Here, we'll.
Thank you. I guess living at fairly high altitude in Los Alamos, New Mexico, I can understand that we're certainly at higher risk of skin cancers in general, but are we at any higher risk of melanoma? Are there any statistics on that?
Yeah, so the state of New Mexico has, I'll say, an average risk compared to other regions in the country. There are data from people who are airline pilots or people who work in the airline industry and are at high elevation by merit of that line of work, and there actually is an increased incidence in of skin cancer, including melanoma, in those individuals, and it's again, a complex interplay, not just of the ultraviolet exposure, but also likely some underlying characteristics of the patient's skin type, but also their underlying immune system and its ability to recognize a pigmented cell going bad in the body. And there's some individuals who may be able to eliminate those cells much more effectively than others.
So I think mainly what you were talking about today for the treatments was for stage 4 melanoma?
Correct.
Has there been any new work on stage 3?
Yeah, so there's certainly a lot of work, but I'll say at the present time, not as much of an advance for stage 3 melanoma. One example of a national study which is just wrapping up is to look at this ipilimumab that I talked about that was used initially in stage 4 melanoma and applying that to patients with stage 3 disease. Those results, it'll be probably about another 2 years or so before we understand them fully, but that hopefully will be applicable. There's also a very large international study that was done with a vaccine in patients with stage 3 melanoma. And although that study did not show clearly a survival benefit in stage 3, by looking at some of these biomarkers that I was talking about, and specifically a gene signature that was present in some patients in their immune cells, not the melanoma, but in their immune cells, that seemed to identify those patients did a heck of a lot better than the group as a whole. And so this gets into, I'll say, the fussy mechanics of the immune system, that one vaccine may work just great in a particular tuning, if you will, of the immune system, but it doesn't work globally. But as we understand that better, we should be able to have treatments for patients with earlier stage. The last comment I'll make is just the way a lot of cancer research works, which is that the FDA has I'll say, a much more liberal set of rules for trying new medications in individuals with late-stage disease, and for some understandable reasons, but you have to show that it works there before you can treat someone with an earlier stage of disease. And so we're still, I'll say, behind a few years in offering things to stage 1 and 2 patients.
Can part of the increased occurrence of melanoma be attributable to increased longevity?
Yeah, so the question is about increased longevity and how that would influence the increase in incidence of melanoma. And that's certainly part of the answer, but if you look within, I'll say, different age ranges, 20 to 30, 30 to 40, there's actually a steeper increase in those age ranges compared to individuals in their 70s or 80s. So yes, age does matter, but there's more to the biology as well.
Earlier you said that probably or possibly 40% of people with stage 1 melanoma will get a recurrence?
Well, so not just stage 1, but stage 1 and 2.
Oh.
So, and actually, so in the context of that slide, it was stage 1 and stage 2 together, and that's lifetime risk. Now, that includes distant spread of the melanoma. So in other words, say someone got a melanoma on their arm, and then there was another site in the lung. That includes that, but it also includes individuals who get second primary melanomas. So an individual who has one melanoma in their lifetime is more apt than the general population to have additional melanomas later on.
Several years ago who had a melanoma in the far back reaches of her nose where the sun never shone. Could you explain maybe the mechanism for that?
Sure. So another one of the, I'll say, the fussy aspects of melanoma is that it is by no means obliged to occur in a sun-exposed area. And so sun-exposed melanomas are about 80 to 85% of the total, but 15% are stories similar to the one that you're describing. And so as we develop from the embryo, the pigment-making cells start on the back ridge or the back part of the embryo and eventually migrate around and become our skin. But some of those melanocytes, some of those pigment-making cells, do not reach their final destination. And so it's kind of weird to think that almost all of us have some internal freckles, but most of us do. And so there are pigment-making cells in the nasal passages, in the bronchial tube, in the GI tract, in the urinary tract, and all other places where the sun does not shine. And so most of the time, that causes no issue, no problem whatsoever. But now and then, the same set of steps, which frankly we don't understand all that well in non-UV exposed melanomas, but those internal freckles not exposed to UV can undergo the same or similar transformation to melanoma.
There was a question on the card.
And so, so this question pertains to an individual who was diagnosed with acute leukemia over 20 years ago, and that was treated with chemotherapy, radiation, and a so-called stem cell transplant. And so that's a very strong dose of chemotherapy, and then to rescue or to help the immune cells to build back up, the patients get cells that can form new blood cells, sometimes from a donor in the family or an unrelated donor, sometimes their own. And so in this case, it was from the patient's own stem cells. there's now 20 years after the initial treatment for the leukemia, a biopsy revealing basal cell carcinoma. And so the question has to do with, based on radiation and the biopsy, is there a greater likelihood to get melanoma? And so I'll say this is an area where there's not a huge amount of data, but certainly there are data from patients who've gotten radiation and chemotherapy for a variety of different cancers. And there is a higher incidence of skin cancer, but it's mostly basal cell and squamous cell skin cancers, not as great an increase in melanoma. The other thing that factors in, though, of course, is we all go outdoors, there's sunlight, there's certainly other environmental influences above and beyond the cancer treatment. Individuals who have medical treatment for not just cancer, but I'll say disorders of the immune system, autoimmune disease, people who are on immunosuppressive medications to keep their autoimmune disease from destroying their joints or kidney or lung or other organs. Those individuals also have a much higher incidence of skin cancer, again, mostly basal, mostly squamous, and to a lesser degree, melanoma. So the status of the immune system is important on the development of other cancers, and that includes melanoma. But to answer this question here on the card more directly, the increased risk of melanoma, I would say, is not significantly increased by the history 20 years ago of the radiation and the chemotherapy. But again, it's not I'll say a patient group about which there is a great deal of data. I'll just make an historical comment and observe that it's wonderful that we have patients alive 20 plus years after transplants for their malignancy. And so when I started oncology training in the late 1980s, although transplant was done, there were no survivors beyond 3 or 4 years at that juncture. And so I'll just say the history that doesn't relate to the skin cancer that's depicted on this is an illustration of some of our advances, but we need to study and understand more what happens to our patients, not just in the moment, but 5 or 10 or 20 years after their treatments.
A really basic question, if you're working in a doctor's office and someone calls and wants their moles examined, how quickly should you work them in?
I'll say there may be more context depending on the individual patient. I'll say within a month or two is fine. If somebody describes a bleeding skin lesion, I would say that needs to be seen within the week. And so this is, there are a lot of things, people pick at things, not to be too graphic, but melanomas that bleed are, I'll say, an especially aggressive subset of melanoma, and so they're described as ulcerated melanomas, and so the prognosis of any melanoma that's ulcerated is about 20 percentage points lower than a non-ulcerated melanoma of the same size. And so long-winded way of saying a month or two probably fine, but if the patient says, and this thing is bleeding, they should be seen soon.
I'm wondering if all of these forms of medication for melanoma that you presented also would apply for melanoma that's spread to form brain tumors. And the second part for that question is if you get brain tumors as a result of melanoma, if standard medication that would normally be used for just a regular, not that there is a regular, but if regular brain tumor surgery or medication could be also used for brain tumors that come from melanoma?
Sure. So some of these new agents do have activity in brain melanoma. And so you could say this is common sense, but if a patient gets ipilimumab, one of these antibodies that I mentioned, and their melanoma in, say, a lung deposit shrinks, there's a very high likelihood that a melanoma brain deposit in that patient will also shrink. Similar with the targeted agents, when the melanoma shrinks in other organs in the body, there's at least an 8 out of 10 probability that the brain lesion will also shrink to the same degree. So these are medications that I'll say can't help individuals with brain involvement from. Well, so that's where it gets murkier. So the immune cells clearly can cross the blood-brain barrier. The antibody, this ipilimumab I mentioned, it might not, and so that's very difficult to measure. It also, we don't think of the brain as having much of an immune system or an immune response, but it actually does, even though we don't understand much about it. And so there's some work that suggests that antibody production within the brain is enhanced by these T-cell directed antibodies through mechanisms we haven't a clue how it works, but yet there's something immunologic going on in the brain that seems to be spurred on by these T-cell directed antibodies. The other part of your question was related to other treatments for brain cancer and how well they work in melanoma, if I understood the question correctly. And so there is a chemotherapy medicine, the name of which is temozolomide, which is commonly used to treat other brain cancers. And it's certainly been tried in melanoma. Unfortunately, it does not seem to alter the course of the melanoma in any significant way. There are individual patients, I'll say, who can and have benefited, and I realize I have kind of an unusual job because I see melanoma patients all day long, and so certainly I and other melanoma specialists have used those medicines, but they do not work nearly as well as this new class of agents, and so I'll say they're still out there, but we're not using them as much. I'll just expand your question a little bit and just say that there's a great deal of work to expand this immune response in the brain with application not just to melanoma, but other brain tumors. And so one of the laboratories at our cancer center is working on listeria, a bacteria, and engineering it in a way that can promote an immune response in the brain against proteins that are present on the brain tumor cells. And so certainly we haven't proven that that's going to be an effective therapy yet, but just to say there's thankfully some outside-the-box thinking that may give us better treatments for patients who have brain involvement from a variety of different cancers.
In addition to sunscreens and the SPF clothing, what other preventative things are out there?
Yeah, the sunscreen is still, I'll say, the least worst preventive measure. There are now some newer UV blocking fabrics, and REI, LL Bean, and various other vendors sell them. The standard teaching is, of course, sun avoidance during the times of the day when the rays of the sun are at the strongest. It's certainly an imperfect answer, and I wish, but not to my knowledge, no. So abstinence, I guess, is the best answer. But
So I have a question about if you have basal or squamous cells, small cancers, do you recommend removing them? And even melanoma, as soon as it's identified, do they really surgically remove it and treat it right away?
Yeah, and so short answer, yes, any skin cancer should be removed, and the majority of basal cell and squamous cell cancers can be managed surgically in the dermatologist's office, and there are well-recognized techniques for that. The surgical approach for melanoma depends on the depth of the melanoma and some other findings from the initial biopsy, and so that often requires coordination not just with the dermatologist, but with a surgeon who is skilled in melanoma surgery, which also includes lymph node mapping and other components to that surgery. So with, and of course, I'll try to make a joke and say, as a native New Yorker, I want everything done yesterday, and so, sooner the better, and so that's good. But in the case of melanoma, getting the definitive surgery, I'll say, within a month of the initial diagnosis is certainly medically reasonable. For basal cell or squamous cell cancers, they have a very different history, and I'll say a much slower progression, and I'm not arguing for neglect, but if it's the week before Christmas when somebody's basal cell cancer is detected and they want to wait until they are done with the holidays and such, that's okay for that individual. Most, better than 80% of basal or squamous cell cancers are cured by that surgery. There are some that are deeper, more persistent, and there are also some topical therapies, and there's some other ways that those are managed. But I'll say one can be a little bit more leisurely with basal and squamous cell cancers than melanoma.
Is it likely that melanoma will also follow those other cancers, or be at more risk for melanoma?
So,
are they associated in some way?
Yeah, so the association, or the strongest association that ties the three together is sun exposure during the lifetime, and especially childhood and teenage sun exposure. And so to that extent they're linked, but the biology of basal cell does not somehow influence or cause melanoma. They're completely separate pathways, and the way that the ultraviolet energy disrupts DNA in basal cell cancers causes a whole different set of changes in, I'll say, cellular adaptation that is distinct from the melanoma. And again, thankfully, the biology is very different.
Based on what you were saying, could you talk about vitamin D3 and whether that is something, and what kind of, should be taking that all the time, or should you still go out a little bit in the sun to get some sunlight and not take a lot of that?
Yeah, I'll say my answer to that is I think a practical one. I think it's unreasonable and unwarranted to ask anyone just to stay indoors. I'll also point out, even though measuring vitamin D has become a routine in many doctors' offices, but it's been a long time since I've seen a case of rickets. I don't know, Eric, have you seen rickets lately? And so real vitamin D deficiency, it's not that common. And so it's okay to take a vitamin D supplement, and certainly to moderate sun exposure. But and even though melanoma is certainly to be respected, some have said it's the cancer that gives cancer a bad name. But so it's not to be trifled with. But I also don't want to have you all leave here today thinking, oh my God, if I'm out tomorrow at noon in the garden or something, I'm going to get melanoma. That's not my message, and that's not, thankfully, not going to happen to any of us tomorrow.
It seems like some of us as teenagers on the farm did everything wrong and seem to be now have escaped melanoma. Why do some people get it and some people not get it?
Yeah, so I'll say your observation is certainly a valid one, and there are lots more people who have had sunburns than have had melanoma. I'll give you a theoretical answer, which is that clearly some individuals make a much stronger immune response against their melanoma compared to others. And so it is believed that our skin immune defenses can eradicate cells that are going bad. And so there's quite a lot of biological variation, though, in an individual's ability to do that. I'll also mention that ultraviolet doesn't only damage the DNA or the genetic material within the skin cells, but it also, to at least a small degree, lowers this kind of spell checking or immune surveillance function within the immune cells in the skin. Exactly why some people are lucky to be able to make these stronger immune responses, I don't have an adequate answer for that, other than we've at least been able to identify some individuals. And by the way, those, or I'll add to it and say that most of the individuals that had responses to the ipilimumab or the interleukin-2 that I illustrated there, if you look hard enough, you can find an immune response that's already there before the treatment. And it's believed that that immune response is amplified by these treatments. And those are the patients who, most of those are the ones who are on the tail of the curve. So their bodies have tried to do something useful against the melanoma. They needed some help because the melanoma is not passive in this. The melanoma is doing many things to evade immune detection, even turn off the immune cells that happen close by to a melanoma cell. And so this is another aspect of melanoma biology, but melanoma cells can emit proteins that actively kill immune cells, which is a sobering thought to an immunologist and immunotherapist. And so the melanoma is no sissy. It's trying to, I'll say, persist and to thrive. But yet, again, when the immune system works, it can do some tremendous things.
We're going to have to wrap up. If people have further questions, you can come see Dr. Curti at the front. Thank you all for coming. Thanks for your support. And I also want to encourage folks to, on the website, you can support Los Alamos Council on Cancer as well with donations, or check out other talks. They're not quite up yet, but very soon we're going to have our other talks up on the website, so you can check those out. Thanks for coming.
Thank you.